Because of some reason, Dr. Rahul, who was supposed to come from Nagpur, has not been able to come due to his personal reasons. We have Dr. Sandeep Karle, sir, who is pediatrician come pediatric hematologist. He is doing excellent work in Parbhani in the field of thalassemia, and as such, his area of interest is also hematology. Dr. Dipti Deshmukh, ma'am, she is my senior from Sion Hospital, and she is doing excellent work in Latur. And Dr. Shraddha, my colleague, all of you know her. So she is also doing excellent work in the field of pediatric hematology at Aurangabad. So first case, it is a 11-month-old girl who has born of non-consanguineous marriage. She presented with multiple episodes of convulsions and altered sensorium. On inquiry, she had a history of fall, followed by bleeding from lips, immediate post-fall, and it was stopped after applying pressure. There is past history of easy bruising noticed by the mother since 6 months of age. On examination, child was pale, tachypneic, hypotensive. She was drowsy, although there was no any focal neurological deficit. There was mucosal bleed and few eukaryotic patches, and there was no any hepatosplenomegaly. It was a hospital delivery. Perinatal parents were uneven filled, and there were no any major bleeding manifestations. In the history, there was significant positive history in the form of family history of mother having menorrhagia. So I will like to ask Dr. Sandeep sir, what important points will you stress in this case in particular first, in the history and clinical examination? I will go back.
Hello. Hello.
Then we will discuss in general. So in this patient, what is the pointer towards diagnosis?
Yeah. In this case, when I say this is a 11-month female child coming with a non-consanguinity of marriage, when we are looking at any child who is coming with a bleeding, so we first think, is it a significant bleeding or mild bleeding? So in our case, the child had fallen, he has history of bruising, and we have seen that she has gone to ICU with hypotension. So it is a significant bleeding. Second thing, is it localized to one spot or is it a generalized? So that is very important when we are considering bleeding disorders. In our case, history of bruising is there, she has CNS involvement, so definitely it is a generalized, we have to think about thing. Then whenever there is a bleeding, we have to think of first, whenever bleeding is there, the first comes in the picture is a vasoconstriction. So vessels are there. There comes platelet, then comes clotting factors. So we have to think whether it is a problem because of clotting factors, it because of platelets. So we consider platelets and vessels together only. And even von Willebrand factor, though it is one of the part of the clotting system, but it is considered with the platelets only. So usually in this case, there is a bruising is there. She has a bleeding from the lips. So it is a mucocutaneous bleeding. So that is a classical in case of platelets and vessel-related problems. She has no history of hemarthrosis, no history of hematomas at injection sites, at vaccination. So in case of clotting factors problems, we see deep-seated bleedings, like bleedings in the joint, synovium, muscles. So that is seen. Another mucocutaneous examples are like history of epistaxis, menorrhagia, melena. So here the mother had a history of menorrhagia. So that again goes more towards platelets and vessels related group of problems. So that here we can come to know. And negative history that no such deep-seated bleedings are there. Second thing, she had a local bleeding from the lips that was controlled with the pressure. So bleeding from vessels and platelets can be controlled with the local pressures. And for clotting factor problems, usually they cannot be controlled with the pressures. And sometimes even the wound continues to ooze for a long time. Clot may form, it may again dehiscate. So there other measures are required in those things. And another thing is, first point was a non-consanguinity of marriage, and she was a female child. So when we look at the consanguinity, so second question as a pediatrician comes in the mind, is it an acquired problem or inherited problem? So that question comes here. Most of the clotting factors problems are inherited, and that's why family history is found. When we look at the inheritance, so all the hematological problems in inheritance point of view, either they are sex-linked, recessive, autosomal dominant or autosomal recessive. So sex-linked recessive problems are hemophilia A and B. So they are usually seen in the males, and females are carriers. So she is a female, so that disease is out of question. Now, because she is symptomatic. So now autosomal dominant and autosomal recessive. So platelet function disorder, platelet related disorder, vascular disorders and von Willebrand and disease, they are found to be autosomal dominant. So usually one of the parent, we can get such history. So if we get some family history here, menorrhagia history is there. So that is pointing to us to certain things.
So to summarize what sir has said, basically there are certain points, can you display the slide, in the history which we have to highlight. Sir has almost covered all the points. What is the age of onset? Is it infancy or later on? If it is the infancy, we are suspecting that it looks like a congenital disorder. And if it is later on, we can have both them. Sex, as a sir has mentioned, if it is female child, then of course, and male child. In male child, we know our X-linked disorders will come into the picture. What is the frequency of bleeding? Location of or type of bleeding. It is a superficial bleed or deep bleed. Very basic, MBBS. So when it is a superficial bleed, we have platelet disorders or von Willebrand factor into the picture. If it is a deep bleed, we have a clotting disorder. What is the duration of bleeding? What if there is any history of previous medications? If there are any associated symptoms that will come. And of course, you have to ask the family history, very important. Okay. So inherited disorder will generally present in the infancy, although it is not a rule. But if it is starting in the infancy, you should have sort of more suspicion that it might turn out to be an inherited disorder. It will be recurrent, it will be chronic. While acquired will be non-specific, it will be acute. So, as sir has rightly mentioned, this is a very basic thing which you should remember. What is the platelet defect and coagulation defect? In platelet defect, we have both quantitative and qualitative. Quantitative is our routine ITP, and qualitative we have platelet function disorders. So in platelet disorders, generally family history may or may not be there. It may occur in male and female both. And of course, it is more of mucocutaneous bleeding. It is short-lived, as sir has mentioned, with the local pressure or with short duration, it can be controlled. And coagulation disorder, they usually will get some family history. We all know hemophilia A and B in common in males. And it will be associated with the deep bleeds, like hematomas, hemarthrosis. Bleeding will be prolonged. And most of the times, local pressure will not be that effective. We know, we have already covered this. So whenever, I will just highlight 1 or 2 points. Mucocutaneous bleeding, platelet function, and remember third one, VWD. Okay? ITP आणि प्लेटेट फंक्शन डिसऑर्डर आपल्या डोक्यामध्ये येतात, पण एक von Willebrand डिसीज एक थर्ड आपण लक्षात ठेवायला हरकत नाही. When you are getting mucocutaneous bleeding. When you have deep bleeding, we all remember hemophilia A and B. I want to remember 2 more disorders. Severe deficiency of factor 7, 10, and 13. And even severe VWD can present with deep bleed. So von Willebrand disease, mild and moderate variant will present with mucocutaneous bleed. But if it is a severe deficiency, you can have deep bleed also. Okay? And third one, of course, other you may forget, but 2 things I want to highlight here. For mucocutaneous bleed, remember VWF, and deep bleed, remember severe deficiency of factor 7, 10, 13, and severe VWF. If you have history of impaired wound healing, along with this, you can keep in differential factor 13 deficiency. And bleeding from umbilical cord, very important to note. Okay? So disorders related to the fibrinogen will come into the picture, and factor 13 deficiency. So 1-2 points just lakshat teva. These are the clues to narrow down your differentials. So to summarize, our patient was a girl child. She had early onset of bleeding in infancy. Predominantly it was mucocutaneous bleed, although post-fall there was suspected CNS bleed, and there was a family history of menorrhagia. Audience पैकी कोणी differential काय डोक्यात येते आपल्या? Von Willebrand will come into the picture, right? So based on history and examination, Shraddha, can you tell us how would you work up this child? What will the screening test? Is there any role of bleeding and clotting?
Yes. So we'll take one question one by one.
Yes.
So workup of
So
this
differential,
child.
you agree with the sir?
Yes. So basically, this is a child who is girl child who is starting the problem early in infancy from the 6 months
Yes.
in the form of mucocutaneous bleed with the positive family history of menorrhagia in mother. So mostly even before platelet I would like to keep von Willebrand as the first, and then the second the platelet function disorder. So in the workup of this child always go for the first screening test. So CBC we will do to look for two factors. First is the hemoglobin. If it is low, it will show us the degree of bleeding. Second is the platelet count, which will show the quantitative deficiency. The third, peripheral smear, to look for the morphology of the platelets and the exact count. We get the idea. And lastly, the coagulation profile, which includes PT, INR, APTT, and the thrombin time. So it depends what is abnormal. Both are abnormal, one is abnormal, one is not, and then we can narrow down our specific investigation. Now the question which you have raised, it's very important, the role of BTCT. Still, we see the investigation, bleeding time and clotting time in many files, especially the pre-op patient who is admitted for hernia, hydrocele, whatever operation, and no coagulation profile is seen. So first of all, these tests are absolute now. They are not sensitive, not specific, and they should not be done routinely, at least in pre-op for the surgical fitness. Okay, so always do PT, PTT, INR, because it is like subjective test. These are not the objective test. So they are falling to the variation and the spurious result. And now lastly the precautions while carrying out
एक
coagulation
मिनिट पुढे
studies.
जायच्या अगोदर
Yeah.
गंमत अशी होते when we speak that BTCT is not to be done, people write PT INR. So what is the mistake? म्हणजे BTCT बंद केलं की मग PT INR लिहितात.
APTT.
APTT कोण करणार? Isolated PT prolongचे what are the differentials? You are ordered PT and INR. INR is interpretation of PT only, right? So practically you are ordering PT only. So what are the disorders which you will pick up with isolated PT prolong? Nahin. Only 7.
Only factor 7.
It's only factor 7, which is the rare form. So when you are ordering PT INR, it is as useless as ordering BTCT. So if you have to order, it has to be PT, INR and APTT. Then only you will get something out of the test which you want to screen. So make it a habit of writing PT. म्हणजे असे धडधडीत हिमोफिलिया दिसतात आणि त्यांचं PT INR 5-5 वेळेस झालेलं असतं. APTT कोणीच केलेलं नसतं. So that should not happen. Make it a habit of writing PT, INR and APTT. Okay. Then what will be the precautions?
Precautions. Now this is very basic. In simple, in 1 minute, whenever you have to collect the sample for PT, APTT, INR, it should be fresh, not from the cannula. Wide bore when you select, don't apply any tourniquet or any squeezing should not be done. Ideally, the needle should be attached to that vacutainer and sample to be collected directly to that bulb. Then your lab person should be besides you with ice pack, so that sample immediately to be transported on ice and to be run immediately. If transportation time is less than 4 hours, you can store the sample at 20 to 25 degrees, but not below or above that. But the transportation time is more than 4 hours, then ideally sample to be centrifuged, the platelet poor plasma and FFP to be isolated, and then the fresh frozen plasma should be transported on the dry ice. So that should be there. The first thing, why our results get spurious? It is because of the squeezing, or we are trying to get the sample from the cannula itself. So that is not to be done. And the most important, your bulb. Now pediatric patient है, तो इसलिए हमने citrate bulb small भेजा है. रेशियो हमने साइट्रेट टू ब्लड का जो रेशियो है 1:9 चाहिए, वो हमने हाफ कर दिया है. दैट इज नॉट टू बी डन. सो योर सैंपल द ब्लड टू साइट्रेट रेशियो शुड बी 9:1 ऑलवेज, एंड द सैंपल 0.5 ml 1 ml नहीं, प्रॉपरली अप टू द मार्क ऑफ दैट बल्ब to be taken, then only the results will be proper. That's it.
पण मग वेन चांगली दिसत होती, आम्ही थोडं अजून घेतलं, काय फरक पडतो?
Because the ratio will hamper, no?
So less is also bad and more is also
exactly,
bad.
yeah.
Right?
So should not be taken up to that mark.
सो तो रेशिओ लक्षात ठेवायची गरज नाही. सायट्रेट बल्बवर बेसिकली जी मार्किंग आहे तिथपर्यंत घ्यायचं सोप्या भाषेत. तुम्ही जास्त पण घेतलेलं चांगलं नाही आणि कमी पण घेतलेलं चांगलं नाही. आणि what is that mixing study? Can you just highlight it?
So now if your results are abnormal, जैसे मैंने पहले भी बताया कि if your results are abnormal, then first you repeat the test. First you see the sampling error was there, transportation error was there, machine error are there. Now everything is concluded, still results are abnormal. Then there are two things. Either we have a deficiency of the factor or we have some inhibitor. So what we do is we mix the patient sample with a normal control sample. Now if results are corrected, okay, that means patient is having deficiency. But even after mixing normal sample, still the reports are abnormal. That means patient is having some inhibitor, and that's why the results are not getting normal. So that is what it is to be done with mixing studies.
So when can you expect inhibitor in a routine setting? म्हणजे आता routine pediatricians समजा sample पाठवत आहेत. So when should they suspect inhibitor? In which conditions you can get routinely? We all know in hemophilia A, when you give repeated factor 8 transfusion, generally after some period there is a chance that they might develop inhibitor. That is a thing for us. But for routine pediatrician,
so known case of hemophilias are there, and if you are they are on regular transfusions, FFP factor, and still even after
an infection
factor, they are getting in presence of severe infections, gram-negative sepsis, then there are chances of getting inhibitors.
So transient inhibitors can be there. Okay, so what she has mentioned is very important, that you mix it with a normal plasma. Normal plasma ne jar te correct झालं तर there is a definite deficiency, and if it is not getting corrected, it means deficiency is not there. You should think about the other causes. Okay, we'll go ahead with the case. So it was child was investigated, PT was normal, APTT was prolonged. बरं आता हे APTT prolonged नेमकं किती म्हणायचं हा एक मोठा प्रश्न असतो.
So तुम्हा जे लॅब असते तर लॅबमध्ये यू गेट दी व्हॅल्यूज ऑफ द पेशंट अँड दी कंट्रोल व्हॅल्यूज, राईट? सो दी कंट्रोल व्हॅल्यू प्लस 10, like anything above more than 10 seconds should be taken with a caution. And if anything more than 18 seconds is definitely abnormal. म्हणजे समजा लॅबनी given your control is 30 seconds and your report is some 32, 34, it's okay, normal. 40 पर्यंत आहे, you should suspect, you repeat it with some other lab or some other time. And if it is like the control is 30 and test report is 58, 68, more than 18, then definitely it is abnormal.
So value to remember is 18 or 1.5 times the normal upper range. The 30 जर normal range जर असेल तर 1.5 times च्या वर जर असेल तर that will be abnormal. हे PTA PTT test ची it is like it is easy to order, but then त्याच्यानंतर रिझल्ट आल्यानंतर खरं काम त्याच्यामध्ये सुरू होतं. म्हणजे most of the patients when we get in our sort of OPD of bleeding disorder, when there is no significant bleeding and they are referred, the first thing we do is we repeat it. Okay, so as Shraddha has mentioned, there are a lot of things involved in ordering and testing the PTA PTT. The best way is जर पेशंट जाऊ शकत असेल तर त्याला स्ट्रेट अवे लॅबला पाठवणे आणि पॅथॉलॉजिस्टला सांगणे बॉस याच्यातनं फिट होत नाही आहे, तुम्ही तिथले तिथे सॅम्पल घेऊन तिथले ते लगेच ते रन करा. दॅट इज द बेस्ट अँड इझिएस्ट वे. इफ यू हॅव गॉट पेशंट इन द OPD which is not fitting into your bleeding disorder and your PTA PTT is abnormal, then call up your pathologist friend and ask him patient to go to the lab and process it immediately. Most of the times you will get the normal results. So what are the tests to confirm? Can you display the slides? So you have got platelets normal here, PT is normal, APTT is prolonged. Now the question is, if APTT is prolonged and there is no bleeding, the first thing is to repeat the sample first. Okay, if isolated APTT prolonged आहे, PT normal आहे, INR normal and patient ला bleedingच नाही, first thing to do is repeat the sample. Okay, and then you can suspect other disorders. But if you have bleeding, you have hemophilia and one blood factor into the picture. So to diagnose von Willebrand disease, you have to do antigen level, factor activity level, and factor 8 level is also important. Why factor 8 level is important in VWF? Anyone? म्हणजे ओन ब्रँड डिसीजचं वर्कअपमध्ये फॅक्टर 8 कशाला करायचं, पैसे पेशंटचे कशाला घालवायचे? So the answer lies here, that in this patient von Willebrand was also low and factor 8 was also low. Why? Because there are 3 types of von Willebrand disease. One is a partial quantitative. 1 आणि 3 these are quantitative defect, म्हणजे फॅक्टर बनतच नाहीये. आणि टाइप 2 इज अ क्वालिटेटिव्ह डिफेक्ट. त्याच्यामध्ये ए बी एम आणि एन च्या मध्ये जायची काही गरज नाही. 3 टाइप जर लक्षात ठेवले तर सफिशियंट आहे. 1 and 3 आर क्वांटिटेटिव्ह डिफेक्ट, 2 इज अ क्वालिटेटिव्ह डिफेक्ट. आणि 2N जो प्रकार आहे, N 2N, there is a definite decrease affinity for factor 8 and type 3 मध्ये सुद्धा factor 8 कमी होतो. तो बेसिकली एक सिंपल लक्षात ठेवा की von Willebrandचे काही टाइप्स आहेत ज्याच्यामध्ये असोसिएटेड फॅक्टर 8 डेफिशियन्सी असते and actually that is the cause of your deep bleeding. Okay, as such von Willebrand factor deficiency should just cause mucocutaneous bleeding. The deep bleeding is because of associated factor 8 deficiency. So you should always order factor 8 levels along with von Willebrand factor levels. Okay. Now coming to the second case, 2-year-old boy who born of non-consanguineous marriage presented with increased swelling over the left buttock since 2 days. There is a history of bleeding from umbilical stump during the neonatal period. There are ecchymotic patches on and off over the body since 1 month of age, although there is no significant family history. Okay. On examination, child was stable, growth is normal, there was pallor, hematoma was present on the buttock, and there were ecchymotic patches over the left leg and abdomen. So looks like a bleeding disorder having mucocutaneous plus deep bleeding. These were the results. Abnormal काही फारसं काही सापडत नाहीये. सिग्निफिकंट ब्लीडिंग तर आहे, इग्नोर करण्यासारखी ब्लीडिंग नाही. बॉय, अर्ली एज, mucocutaneous plus deep bleed, history of bleeding from umbilical stump, no family history. आणि जे काय आपण बेसिक स्क्रीनिंग टेस्ट केलं आहे CBC, PS आणि PTI आणि APTT नॉर्मल आहेत. सो बिफोर आय आस्क डॉक्टर दीप्ती मॅम, एनीबडी इन द ऑडियन्स? यस. ओके, फायब्रोजन डिफेक्ट इज वन ऑफ द डिफरन्शियल विच सर वॉन्ट टू टेल. अजून कोणी? फायब्रोनोजेन कुठे येतो क्लॉटिंग कॅस्केड मध्ये? इट इज अ फॅक्टर 1. 2 is thrombin and 1 is so you will expect PT and APTT to be deranged. अजून काही differentials? 13. Okay. Von Willebrand will come into the picture and platelet function disorders, right? So Dipti ma'am, so these are the 3 differentials. How will you differentiate between these disorders? What will the test which you will order?
When you have normal platelet, count is there. That means quantitative platelets are okay, but you can have qualitative defect like platelets. Maybe there is functional defect like platelet aggregation defect or some syndromes are there. Glanzmann thrombocythemia, Wiskott-Aldrich, Chediak-Higashi, but in these 2 cases there are some associated other symptoms also. When you have PT and APTT normal, that means your pathway till factor 12 is okay. The next factor 13, which is fibrin stabilizing factor, it is having some deficiency. That's why the clot is being formed, but it continues to be bleeding because of the factor 13 deficiency. Next is you can have some vessel dysfunction or some enzyme deficiencies.
Right, like scurvy or something like that. So platelet function आपल्याला सगळ्यांना माहिती की पहिल्यांदा इंजुरी झाल्यानंतर सगळ्यात पहिल्यांदा प्लेटलेट तिथे येतात. प्लेटलेट पहिल्यांदा वेसल वॉलला adhesion, right? Platelets will get adhered to the vessel wall and then platelet will get attached to the platelet. So that is a aggregation, basic MBBS. So if adhesion is defective or aggregation is defective, these are the 2 disorders where you will have platelet function disorders. Factor 13, as sir, madam has mentioned, and on-buildment factor. Okay. So there is something called as clot solubility test. Madam has just touched upon it. You are able to form the clot, but you are not able to maintain it. It is getting dissolved very fast. So what you do is you put some dissolvents and you observe की किती वेळामध्ये तो clot dissolve होतोय. जर तो खूप जास्त early dissolve होत असेल त्याचा अर्थ clot is not stable, and that is indicative of factor 13 deficiency. So Shraddha, what are the treatment options if you have diagnosed factor 13 deficiency in this patient?
So the best option is what is deficient, that should be filled. So it is a recombinant factor 13, okay, but which is not easily available in India. It is fibrogrammin, or the brand name is Treten Itscum. Now what we need to do is we need to see, basically when we replace this factor, the dose and duration, it depends on the half-life of the factor. Now the factor 13 has the longest half-life. It is almost 7 to 12 days. So we need to replace the factor with long duration, need not to do it repeatedly. And even if we raise it up to 3 to 5% of the activity level, that is sufficient. But our problem in India, it is the non-availability or the cost. So the solution to this is the FFP or cryo. So the cryo is better than FFP because volume is reduced, and the other factors which are not necessary, we can avoid it. So the best thing is to give recombinant factor. If not, second is the cryo. If not, then FFP.
So to complete the discussion, can you touch upon what are the factors? Let us keep this case aside. What are the factors available in the government setup nowadays?
So in government setup now, the factor 8 is available easily. In fact, we have a very good supply from the government. To some extent, factor 9 is also available, and even Novo 7 is also available.
That is factor 7.
So if you have any patient of hemophilia or factor deficiency who in emergency, who needs immediate, you can directly contact either your local hemophilia society or any government setup who have daycare center. Like in Aurangabad, we have Chikalthana Hemat-oncology daycare center. There they try to make it available maximum at least 9 months per year. That is a very good number.
So coming to the last case, just give us 5 minutes more. 5-year-old boy, female child, sorry, presented with red patches in both legs. There is no history of fever, lump, no any medications, no vaccination. Basically, a well-looking child, 5 वर्षांची मुलगी, जिला म्युकोक्युटेनियस आणि superficial bleeds आहेत. So Sandeep sir, what are your differentials in this point?
She is a 5-year female, as such.
In short, because we are running out of time.
Growth normal, well child, not sick looking. Only
So point I have highlighted. What are your differentials?
First thing I will think of ITP, because that is the most common disorder.
Right. So looks like ITP, but as we have already told that it is not ITP. We are not included. So what other things you will keep in mind?
Sir, I will like to ask for the mother, because aunt is giving the history. So history of, we don't have a history of medications and admissions in last whatever 5 years. So history we have to give.
What sir wants to highlight over here is that, is there any history of when the bleeding has actually started? Is it acute bleed or is it a chronic or persistent bleeding? And this is just a recent episode of one of the episode. That is the point you want to highlight. पण समजा त्याचे इन्व्हेस्टिगेशन्स मध्ये केलेत आणि हे आता परत आयटीपीच वाटतंय ना, हे सीबीसी आयटीपीचाच आहे परत. आता काय प्रॉब्लेम आहे?
Past history, mother.
ठीक आहे. आता सपोज इट इज नॉर्मल and looks like ITP. Yes.
When you have a thrombocytopenia, but always correlate that thrombocytopenia with platelet morphology or the peripheral smear. Now in this picture, if we see, we can see the platelet, but they are very large. Platelets are not that large. It's almost a bunch of 15-20 platelets making one platelet. So these are the large platelets with low count. So this is platelet function abnormality. So we need to do the platelet function study.
So point to highlight here is peripheral smear examination. That was my point, that despite CBC being showing low platelets, the peripheral smear, if it is carefully evaluated, the clue will be in the peripheral smear itself. Okay. So there was a history of bleeding and platelet count were 70,000. There was previous history that child was actually already labeled as ITP. Child had received IVIG and other treatment, but there was no any improvement. So Dipti ma'am, can you quickly go and what are the red flag signs? And when you will say that अरे हे थोडं ना ITP सारखं नाही वाटत, त्याच्यात काहीतरी बघायला पाहिजे आपण.
In previous talk, Dr. Shraddha has already mentioned ITP typical child is playful, age group is more than 2 to 10 years, then no family history, and it is decided by some viral illness. So when age group is less than 1 year, you should suspect some other illness, maybe primary
ITP
immunodeficiency.
4 महिन्याच्या बाळाला किंवा 6 महिन्याच्या बाळाला होऊ शकत नाही असा मेसेज आपण द्यायचा आहे का?
It is not like that, but you should suspect some other immunological deficiency, because primary immunodeficiency may present with thrombocytopenia.
No, my question is that if you have a 6 months or 8 months child who is straight away looking like ITP, so can we treat it as a ITP or should we always have that suspicion?
You should have suspicion.
Okay, so you can get ITP. म्हणजे as early as 3 months of age you can get ITP. म्हणजे we don't want to give the message की less than 1 year ITP होत नाही. That is not the message. Message is if you have treated the patient and it is coming back to you, you know, after 1 month, 2 months, 3 months with no improvement, then you at least have in your mind त्याला परत स्टिरॉइड दिलेत की लगेच IVIG द्यायचं किंवा दुसरं देत नका बसू. You have treated it as ITP. But you are not seeing the improvement, so keep it in mind that this may not be actually case of ITP to start with, right? Similar thing is adolescent. What will be the differential?
SLE or some
Yes.
collagen vascular diseases can be
Yes.
there. Then systemic symptoms like organomegaly and lymphadenopathy is there. You can suspect of malignancy. And previous family history like von Willebrand disease, and if it is a male or female child, you can suspect some X-link or other disorders.
Right. And repeated infections also, you have mentioned that you should rule out PID. So unwell child, hepatosplenomegaly, lymphadenopathy, rule out malignancy. Inherited bone marrow failure syndromes, you have to examine the patient properly. Investigations मध्ये if there is anemia disproportionate to your degree of blood loss, other two lines चा काहीच अफेक्ट व्हायचा संबंध नाही ITP मध्ये. ओके, सो अॅनिमिया आणि WBC म्हणजे HB आणि WBC जर अफेक्टेड असले तर रेड फ्लॅग साइन, abnormal bleeding profile and deranged liver or kidney function. So Shraddha, can you quickly in 1 second tell large platelet? We'll not go in detail.
Yes.
Maybe you have already covered
So,
platelet function. So can you just highlight
yes.
this one?
Yeah. So the large platelets causes are many. We need not to go in detail, but most commonly is Bernard-Sollier syndrome, gray platelet syndrome, and May-Hegman anomalies. These are the commonest one. The second question he asked, what is the cause of spurious thrombocytopenia? So the most commonly when you see the CBC में low platelets, first you need to see the peripheral smear, whether it is matching, whether there was a clot in your EDTA sample, and sometimes clumping happens. All platelets, they get clumped with EDTA. In that case, you can just reconfirm the CBC in citrate bulb and to do the peripheral smear examination to see for the manual count.
So basically जर pathologist ने सांगितलं सर smear और platelet adequate वाटताय तो respect him. That platelet count should be respected and not your coulter. Pathology जर बोलला नाही सर मी smear बघितलाय त्यात platelet adequate आहे, so it is adequate, and go ahead and think about other differentials. So what are the tests where you like to confirm platelet function disorder? There are different tests. We'll not go into detail of that. Treatment of all platelet function disorders, unfortunately there is no definitive therapy. You can just give symptomatic treatment or platelet transfusion. So only 3 questions for audience. There is a bleeding, platelet count is no. आता हे जे झालेलं आहे त्याच्या व्यतिरिक्त असणार आहेत बरं, तो पण एक क्लू, नाही तर परत तेच डिफरन्सेस नका जाऊ. So bleeding is normal. Bleeding is there, platelet count is normal. PT, APTT both are prolonged. थ्रोम्बिन टाइमचा आपण डिस्कसच नको करायला, एवढं जरी केलं तरी चालतंय. Yes? Okay, right. What is the clue?
Sorry, sir, we are short of time.
1 second. Yes? Yes. And if the thrombin time is normal, same patient? सेम पेशंट, PT APTT prolong आहे आणि थ्रोम्बिन टाइम नॉर्मल आहे. vitamin K.
Vitamin K deficiency.
Okay. Our common emerging disease of Niva. सगळंच ॲबनॉर्मल आहे. प्लेटलेट पण कमी आहेत, थ्रोम्बिन टाइम पण ॲबनॉर्मल आहे, पीटीए पण प्रोलॉंग आहे. अजून तुमच्यासाठी जास्त कॉमन आमच्यापेक्षा DIC. थँक्यू, थँक्स अ लॉट. So take home message, BTCT not to be done routinely, PTINR sample ratio to be maintained, bleeding disorders which are not picked by routine test, factor 13, VWT, platelet function. And you should remember red flag signs when you should know that it doesn't look like ITP. You should have suspicion and work up those patients. Thank you, thanks a lot for giving us the opportunity.